with powerful evidence from the Dunedin study and now with what the British Medical Psychiatric Journal has published. Children who have ADD, that can't manage anxiety, can't manage impulse control before the age of 12, guess what? They ain't gonna live as long. If that persists into adulthood, oxidative stress. Google it, oxidative stress, lifespan and health span, 3 words.
Have to make sure that we're treating the child as a whole and not just a maxilla. All right, the biggest problem is there's no one on earth who can't expand a maxilla. But if we don't marry up the mandibular arch to retain a functional occlusion, then it's just literally a waste of time. As dentists, we're obsessed by gadgets. We're obsessed by appliances. We're obsessed by stuff that we can make. What we've got to do is understand that a child's posture, how they fight gravity in this existence, is something that the parents can help when they raise their children. And it's up to us to teach parents how to improve the general oral posture and the nasal posture of a child.
Dentistry makes a living at fixing a completely preventable disease. Tooth decay was not a problem throughout human history. We've gone 300,000 years with no cavities, and malocclusion only 400 years old. So we go 300,000 years with no cavities and no malocclusion. We've got an industry, Simon, and you and I are pissing people off.
All right, welcome everyone. Good evening, good morning if you're dialing in from Australia. I can see there's about 100 people so far. We've had over 500 registrants. Hopefully we'll get a couple of hundred, and the rest of you will be watching the recordings, which we'll send out hopefully tomorrow. Welcome, Shushma from Vancouver, and we've got Donna. Welcome. Kevin White from Kentucky. Karen from Michigan, Grand Rapids, welcome. Bruce from Sin City, Las Vegas, welcome, Bruce. John from Tennessee. Who else do we have? Hillary from New Jersey. We have an international group. Interdeep from Ontario. Anyone from outside of the US? I'm in New York. Hey, Kevin, good evening. Good to see you again, of course, and my brother, Dr. Simon Wong from Melbourne, Australia. They're all here getting ready. We'll just, I think, get started any minute. We're already spot on 9 p.m. Eastern, New York time, 8 p.m. Central right now, for those of you joining from the East Coast. Very excited to have our very special guest, Dr. Kevin Boyd from Chicago. And my brother, Dr. Simon Wong. I'm Kian Wong. You've probably all been getting texts and emails from me from Postural Orthodontics headquarters, one of the headquarters in New York. My brother's based in Melbourne, Australia, where we grew up. What are we doing tonight? We're very excited to discuss something very dear to our hearts. Let me just share my screen, if I may. Controversies surrounding early interceptive orthodontics. Dr. Simon Wong and Dr. Kevin Boyd. And Kevin sent us a whole bunch of research papers. Very exciting. We're going to share it with everyone. There's over a dozen papers that he sent and articles on how we can optimize our children's health and lifespan, which is why we're here tonight. Firstly, Kevin, welcome. Simon, welcome. And welcome to the hundreds of you who are joining us from around the US and around the world. Today, it's a preview, as mentioned in the registration page. It's a preview of our 6th annual 2-day intro to our early interceptive postural orthodontics program for airway-focused dentists, especially, if you want to help, children in that 4 to 10 range. This year, we're going to be having it live streamed via Zoom, so you can watch from the comfort of your home on Friday and Saturday, June 6th and 7th. Starting a little bit later in the day, 5 p.m. New York time to midnight, 7 hours both days, or 2 p.m. to 9 p.m. for those of you on the West Coast. For those of you in Australia, it'll be starting 7 a.m. That's where my brother will be beaming from, Saturday and Sunday. So stay till the very end. I know a lot of you guys have been asking about this event, and we've got a very special, final offer, early bird tickets for the end of April. That's that we'll mention at the end of tonight's presentation. So who do we have as our main host? I'm going to pass the baton over to my dear brother, Dr. Simon Wong, who's the founder of Postural Orthodontics and the co-author of GOPEX, Good Oral Posture Exercises. Dr. Simon Wong is the principal of Natural Smile Center in Melbourne, Australia. Is focused on early childhood craniofacial development and malocclusion correction. He's one of the world's leading experts in orthotropics, facial growth guidance, and we're just simply coining his protocols early interceptive postural orthodontics, which is evidence-based and much more suitable for a wider adoption. It's created a unique set of lower and upper arch expansion plates and GOPEX, good oral posture exercises. He's got hundreds of cases that are currently being researched at top dental universities around the world. And you may have seen him recently on Netflix's Open Wide documentary. Simon, welcome. Are you there?
Hello, hello.
Welcome, welcome. Are you going to introduce Kevin formally for us before we
Well,
get started?
we're very lucky to have Dr. Kevin Boyd grace us with his knowledge and his presence in our June event. He will be one of the keynote speakers. Kevin is a board certified pediatric dentist with 2 decades of experience. He's very much focused on health care for infants, children, adolescents with disabilities and special needs. He has done much in the way of research in tooth decay, obesity, and type 2 diabetes. And he has very much focused on nutritional management for children's health. One of the things that he has been recently focused on is his combined work of his clinical practice in Chicago for diagnosing and treating interferences to normal growth and development, and most recently looking at research in what we would call the lifespan and health span of young patients, children within the community. So
Welcome,
thank
welcome.
you for joining us, Kevin. I understand you're also going to be speaking in Malaysia in the upcoming conference, Integrative Airway Summit. And I think you and Sharon Moore will be talking about how growth and development, airway affects the rate of biological aging, oxidative stress, and a lot of the basic health sciences, physiology and biology. So we're very, very fortunate for Kevin to also share this information in our June event for those who can't make it to Malaysia.
I'm going to sign off and leave it to you guys. I'll be back near the end. Cheers.
All right. So one of the things, Kevin, that you and I have really been directing our attention towards is children in the primary dentition and the early mixed dentition. So for your primary interventions under 6 and my primary interventions for under 8. As a pediatric specialist and myself as a primary care general dentist, we have historically been directed by the orthodontic standard of care to treating much later in the permanent dentition. In teenagers of the, after the 13-year-old canines have come through. I wanted to explore a little bit about why there was a shift from the first 100 years of orthodontic practice, from treating the entire age range of children, teenagers, and adults, to just obsessing about teenage alignment. I suspect that in the later half of last century, there was a big drive to try to verify through evidence bases our ability to correct skeletal malocclusion. We ran enormously expensive and wide-ranging randomized control trials that were published after often 10 or more years of research and development in multi-centers. The two pivotal ones were from Tulloch and Profit in 2004, and then later on O'Brien in 2009. And they basically looked at how effective functional appliances were for class 2 division 1 malocclusions and compared it to what we call a one-phase treatment, which is just fixed braces, in comparison to two phases treatment, where we would try to get skeletal change in the mixed dentition and then later tidy up in the permanent dentition. The outcomes of these decade-long studies, level 1 evidence, randomized control trials, was that we actually have no influence on skeletal growth using functional appliances. And that, in fact, the children benefited more from a shorter and less invasive treatment if they were just treated in the late part of their growth and development, which is permanent dentition. As we were moving into this concept of evidence-based dentistry, that became the new boundary. We were effectively told, don't waste your time trying to modify growth. Growth is effectively genetic based, and that it makes the most sense just to put the fixed braces on at 13. We used this in the last generation of orthodontic care as the foundation. And so those of us who work with younger children are frowned upon. And I wanted to recognize the immense amount of time, money, and energy that was put into these trials, and why they categorically showed functional appliances do not change skeletal growth pattern. But I also wanted to side note the fact that since that time, we have recognized that there is more to life than just correcting a skeletal malocclusion for the sake of getting teeth to line up. That you have spent the last 20 years of your life focused on helping to improve the health span of children from a medical perspective, and how developmental imbalances in the growth have found to be hugely impactful on the growth and development and the health and well-being. And from my perspective, my understanding from work done by Peter Bushang at Texas A&M on posture, redefining the work that was done by Bjork on Roberts of the University of Indiana, who did basic science research to confirm that the genetic component of influence finishes at 18 months, and that environmental factors are hugely important from 18 months onward once the Ds erupt into place. That functional appliances, as confirmed by Peter Bushang, actually don't work, and that it's posture and true mandibular rotation that determines the eventual chin position of the mandible. So although we proved one of our tools as being a complete waste of time, in the last 25 years, we've learned that airway disorders, general health and well-being, the state of anxiety and mental status and neurocognitive behavior of children are immensely influenced by disease that is not checked in the early years. So after that kind of long-winded introduction, I just wanted your thoughts on what has brought you the confidence to be able to teach now that we have to treat before 6.
First of all, Keon said children 4 to 10 years old. And that to me is like saying adults 20 to 110 years old. That span is too large. And really, he did his best. I'm not criticizing him, but that's really how the world looks at it. Before 10 in the orthodontic world, as we were directed, as you put it, Simon, that, you don't get in before 10. That's insane. And Bouchang and everybody shows functional appliances don't work. Well, they don't work the way that they're diagnosing, assessing risk, and when they're applying them. Of course they don't work. I would agree, I don't defend that. We have to start changing morphology, but we first need to put what I call a new angle. Angle, as in angle, class 1, 2, and 3. I call a new angle class 4, bimaxillary retrusion. And Simon, well over half of the children that we're treating class 1, 2, or 3. And thank you, Bill Hang, for introducing us to McNamara's 1982 paper, that most class 2 malocclusions are not just mandibular retrusion, they're also maxillary retrusion. Nobody talks about it anymore. Every adult that could benefit from a maxillomandibular advancement surgery, what by nature, by definition, must be their pre-surgical diagnosis. If maxillomandibular advancement solves the problem, the skeletal problem is maxillomandibular retrusion. And we know
Absolutely.
it begins in early childhood, but it's subtle. Let's let it get more complex. That is the orthodontic paradigm. Let's let it become more complex, and then let's treat it. What disease, what organ system in the human body would be allowed to go from pre-stage 1 disease to stage 4 before we get in and start, I don't need to go there. You understand
Yeah.
it. I hope
Well,
other people will make that analogy.
Peter Bishang and Wang's work in 2009 verified using the historical database from the growth studies in the 1900s that malocclusions are well established by 5, and that any vertical component, which is that dual retrusive nature of growth, is usually locked into place, and 2/3 to 3/4 of them never improve on their own.
And there's lots of pre-World War II scientific clinicians that understood a distal step molar upon eruption of the primary second molars. All right. If you have a distal step molar, guess what? You have a class 2 skeletal dental malocclusion for life. It never self-corrects, never, and is always associated with maxillary transverse deficiency. I can defend that. Argue with me on that, please. It is a fact. And it has been completely the orthodontic profession. They've known this. They're the ones who taught it to us. Distal step molar never becomes anything but a class 2 skeletal. And now that we understand the comorbid association of class 2 skeletal retrusion and maxillary transverse deficiency, they're always together. They will either obviously or later on, not obviously, but, it's going to be a comorbidity with sleep and breathing problems, which is a comorbidity with cardiac, neurological, hearing, seeing. Forget it. Just get off. If you don't want to do this, just understand, please assess risk. The American Dental Association says it's incumbent upon anybody who sees children, whether it's an orthodontist, pediatric dentist, or a primary care general dentist like Simon and many others, they're the ones who are doing most of the work. You must assess risk. It is incumbent upon everybody to assess risk and inform the parents. This child will be or already is at risk for sleep and breathing disorders, and they will be comorbid with all kinds of systemic illnesses. Just make them aware of it. It doesn't mean your kid is going to have ADD. They might, but it's just you make them aware of it. You don't have to treat. Please, people do not, everyone listening here today, it's not your responsibility to treat these kids. It's your responsibility to inform the parents. This is a risk factor, and it's in the literature. I've submitted 12 articles. Please pay attention to them.
Well, absolutely. I mean, one of the fallacies that I tried to reveal in my program for general dentists, primary care dentists, pediatric dentists, is that that definition of airway dentistry is confusing, right? It gives the impression that we as dentists need to treat airway disorder. And the reality is our license as primary care dentists does not include any component outside of the oral cavity. We are not licensed to treat airway disorders. However, sleep physicians and ENT surgeons rely on auxiliaries to screen for disorders so that they can step in. And guess what? Even though dentists don't like thinking of themselves as auxiliaries, as far as medical intervention is concerned, we are auxiliaries. And we have a unique opportunity to be looking after people from cradle to the grave. And we're seeing 1-year-olds, 2-year-olds, 3-year-olds, all the way through until they are 90 years of age. And because of that, we have touch points with children many-fold over the primary care medical doctors. The pediatricians let go after the first year. We start seeing them, and we continue to see them for their entire life. So there are resources available, which I've been able to collate, that can help the primary care dentist literally in a 10-minute evaluation screen effectively enough for a qualified referral to either sleep physicians or ENTs. What we don't actually want is for dentists to panic and send every kid who walks through their door for sleep studies and ENT evaluations. We don't want to be not that dentist again, sending us people who don't need ENT intervention, who don't need sleep studies. There are simple things that we as dentists can do on a routine basis in our medical history exam and our normal dental evaluation screen effectively to help our colleagues out. You've been teaching this for a very long time. I have not been doing it for quite as long, but I've been able to formalize a protocol that I can share with the dentists who are interested in. And I'm just very fortunate to be able to follow in your footsteps, Kevin, to be able to continue championing the concept that it's not just about fitting teeth together. It's about looking after the children who are attached to those teeth.
So I had from a colleague today, just before this pod, I just read it, and Kev, and I'm treating his kids. He's a dentist. He comes, from another state. I've got, and he didn't give me too much information, but this child needs to see a sleep medicine physician. Well, here's what the problem is, Simon. Relative to kids who need to be evaluated by, let's just say, risk assessment for sleep disordered breathing. That's why the ADA came up, with this. We have this CAS screener that we're, testing. But what happened, and I happen to be very close to the head of sleep medicine at one of the largest networks of pediatric sleep labs in the world, actually. It encompasses 4 states. And he's like, look, I'm responsible for 280,000 children. I can't see them all. So what I think we should do is train oral health professionals, not just orthodontists and pediatric dentists, but primary care general dentists and myofunctional therapists and speech pathologists. And, just there needs to be so many people involved in child health care that can screen these kids and really triage and make sure these are the ones that I need to see. The head of sleep, he's an internist, Darius Logmani, his name is. He's brilliant pediatrician, sleep medicine doctor, internist, and he's training so many people to make it so that he doesn't have to see everybody. He can't see everybody. And we are all getting competent. And no, send them to me first. I can probably recommend something. Either if I can't do it myself, I know people who can really help this child. That's how it's got to happen. We're not
Yes.
we don't have enough sleep medicine physicians. So that's key. And Simon, you are the one who told me, Kevin, make the analogy between myopia, nearsightedness. Would any good physician look at the parents of a 4-year-old who was severely nearsighted, high myopia, they call it, and let's wait till he's driving a car. He might be blind by then, but let's wait till then to give him his first pair of spectacles, as you said. I say glasses. I use that analogy. Myopia is so similar. If you ignore it before the age of 5, you are going to have such a problem on your hand, and you can change the direction of that child's life just by helping them see. Well, it's the same thing. If you create
Absolutely.
structure and function conducive to nose breathing while they're awake and asleep, you will change the course of this child's life. They will live longer, and they will stay healthier longer into their extended age. So that's what this is all about,
Yeah.
as far as I'm
I mean,
concerned.
going to that concept of short-sightedness, even if we can't cure it, right? Even if we can't cure it,
We can't. You can't cure myopia.
right?
It's not curable.
Doesn't the quality of life of the child improve by correcting their vision? Right? So even if we can't cure malocclusion, doesn't improving the structure of their face and their jaws and the function and posture improve their quality of life? And that's a question
Absolutely.
we have never,
No, it's in the literature.
ever
It's in the
asked
literature.
nor answered in the dental profession. If we look
Yeah.
at the medical literature, that's all they're interested in. So, Kevin, tell us a little bit about what you're focusing your attention on now, as far as the biology of the health span.
Yes. Okay. Well, I won't have enough time, but I'm hoping to excite some curiosity in people, that they will take our course, that you will go on your own and dig. This is all out there in the literature. It's called oxidative stress. Simon, you didn't know it and I didn't know it, but probably for the last 15 years, we have been helping children optimize their ability to have a better quality of life in the short term and long term. And what does that mean? That means, Simon, if we reduce oxidative stress, and this is something that I can teach, I have really done a deep dive in what oxidative stress is. Some people call it sympathetic overdrive. It is a predominance of reactive oxygen species, free radicals. What does that mean? We memorize that for a test. If we balance early in life, let's just say if we don't balance, if a child is under oxidative stress, and the main research comes from children who have cancer. I spent the first part of my career dealing with mouth problems of kids who had oncology problems. They had leukemia, they needed bone marrow transplants, and you know what? The stem cell replacement is what they call it now. I helped with the mouth problems. These kids had rapidly dividing tissue, mucosa. It's the same as cancer cells. Anything that will knock out a cancer cell will knock out the mucosa and in the eyes, the skin, and the oral mucosa. They're all subjected to something called graft versus host disease. It's where the actual therapy attacks not only the cancer, but it attacks all rapidly dividing tissue. I won't go into that too much, but that's how I spent the first part of my career. Well, these kids that we did all this treatment on with radiation, full body irradiation, cytotoxic drugs, we helped them survive that cancer. But guess what's happening to them? Reactive oxygen species. These kids survive the cancer, but they're aging faster. Their rate of aging, their biological rate of aging is accelerated incredibly. That is an extreme version of it. And that's my experience. Okay, when we got a little kid who's overweight, obese, okay, we got to start taking body mass index on kids. I'll talk more about that later, but that creates oxidative stress in the short term. If there's too much of it, their cells stop dividing. Mitotic cells do not divide. It's called cellular senescence. We know that with aging people, 80-year-olds, 70-year-olds, they get cellular senescence. They get amyloid plaques. Little kids get it on a short-term basis, but it's setting them up to age prematurely and have a shorter lifespan and a shorter health span. Way too much. I'm giving you way too much information here right now, but the tie that binds is called oxidative stress in the short term. Little kids can recover, but you keep doing that to them. You keep doing that to them. They're mouth breathers. They don't sleep well. They're overweight. They're eating crappy American food. All these things. You know what? It's going to catch up to them. And when they're 30, they're going to look like they're 50. And facial aging is all part of this. This is all evidence-based. I can back this up with powerful evidence from the Dunedin study and now with what the British Medical Psychiatric Journal has published. Children who have ADD, that can't manage anxiety, can't manage impulse control before the age of 12, guess what? They ain't going to live as long. If that persists into adulthood, oxidative stress. Google it. Oxidative stress, lifespan and health span, 3 words. And this is an intro. I'm not going to get everybody on board here. I've submitted some supportive articles. This is the rest of my career. This is what I'm going to dedicate myself to. Minimizing oxidative stress at the earliest possible age. And guess what? It doesn't start at birth, Simon. It starts in utero. If mothers are under stressful conditions, if they're not breathing well, if they're overweight, and I'm going to show all this in Malaysia. I'm going to show it in Denver. This is it. I mean, this is a big deal. And who would have thought? I went into dentistry. I'm going to fill cavities. This is like such a responsibility and opportunity for our profession. And Simon, we can teach it to them. We can teach it to them.
The biggest hurdle that we as technical people face is that the technical aspects are so involved and require so much training that we lose sight of the first principles of diagnosis, treatment planning, goal setting, and looking for curative measures. We spent the first part of our studies learning about the basic sciences. And although that just seemed like a complete waste of time, just a hurdle that we had to jump to get into how do we put the injection in, how do we drill the cavity, how do we fill it, right? The reality is, after we've learned how to do these things, after we've spent decades like you and me, we've realized that production line is never ending because no one is stopping the damage from occurring in the first place. And as you said, if we look back at the basic sciences, at cell biology, at physiology, the answers are there. We're dealing with lifestyle, long-term impacts. And if we don't step back and step back and step back and look at it from a bigger perspective, we will always be putting out fires that are never ending. It is our mission. It is the point of our lives is to help spread the understanding that apart from the technical components to it, we actually have to learn to understand the root causes. And going back to the very, very basic sciences, we already have the answers. The stresses that children are put through today are completely different to the stresses that we as a species were subject to. Because of the change in these modern day stresses, we're dealing with modern day diseases that were never ever part of the evolutionary protective mechanisms. So hopefully you've got a few insights and answers for people to start to see from the taking away from the macro and bringing it down to the micro, and then conversely the opposite side as well. Understanding the micro so that we can deal with the macro.
In the micro is oxidative stress. People need to learn and master that. Look, I know enough to be dangerous. I got caught by this about 4 months ago, and now I'm invited into 2 large government grants because of this hypothesis that these children are undergoing intermittent, temporary, transient, sometimes chronic and long-term. But that's what's going on at a molecular level. Simon, this is something that I'd like to bring up. There's 278 people here now. Anyone who's been to Chicago in the winter, if you're downtown and you're driving, you're going to get diverted in the winter, because what happens when the snow falls and the ice forms on the on the pavement of the streets, we have potholes that rival the moon. They're huge. They swallow up cars. Okay, well, this has been going on since the automobile, 100 years. And do you know what? We have a union here. We have unions, we have trade unions of all kinds of construction workers. They're called the pothole fillers. And they were formed in the 30s. And you know what? They got presented with a proposal for an asphalt. This was in the 70s, for an asphalt that resisted forming potholes. And it was going to solve that problem. Unfortunately, they didn't put it up as a referendum to the whole electorate in Cook County, Chicago. They left it up to the members of the Pothole Fillers Union. And guess what they said? Do you approve of this? Can we like start using this to repair potholes? And guess how many thumbs up and thumbs down there were? They didn't want it. Why didn't they want it, Simon? Why did they not want an asphalt that resisted potholes?
Because they didn't
They'd
want
be out of
to.
a
They wanted to have lifelong retention value of their services.
I liken it to a clergyman, a minister who becomes an atheist. What's he going to preach about on Sunday? This is all he knows how to do. Okay? So I made that whole story up to illustrate it's not true. It's total BS. Okay. But I do it to illustrate a point. Dentistry makes a living at fixing a completely preventable disease. I'm also a nutritionist. I have a master's degree in nutrition and dietetics. And my research was focused on tooth decay and obesity back in the 70s, back when those things weren't even connected. Okay. And then I am really pursuing postdoc work in anthropology. Tooth decay was not a problem throughout human history. We've gone 300,000 years with no cavities. And Malocclusion, only 400 years old. So we go 300,000 years with no cavities and no malocclusion. We've got an industry, Simon, and you and I are pissing people off. Who wants to do what they do? You can't make a living at it. And I don't know how to do anything else. Nonsense. You can make a great living and do a great service to mankind by diet counseling, ultra processed food. It's not sugar, it's ultra processed food that promotes gum disease, what I call plaque mediated disease, and tooth decay. And the texture, the softness of ultra processed food is what's giving us these myofunctional disorders and malocclusion. Period. Who wants to do that? Well, that's all I do now in Chicago. And I'm busy as hell. And I got people coming in from all over the world. It's got to be more than me. I need more people doing this. And you, Simon, oh my God, you're producing the research. What you and Bouchang did is amazing. It's a great study that you did. People need to know about it. So anyway, I'll refrain here.
I think one of the things that we should consider is obviously we're going to continue this conversation well into the June program in more detail. So right now we're just chit-chatting about what we're going to talk about in the upcoming event. But perhaps we can open
Hi, Simon.
the forum back to
Yeah,
Kian,
there's some
who can tell
questions
us.
that have come in. So let's just answer some questions of 5 or 10 minutes, and then we can talk a bit about upcoming events. So some questions, I'll read them out. Anonymous attendee, in mixed dentition, if I have a 1646 in X bite, I bet cross bite. Simon, you better read this. Some technical dental terms that you better
I
take
got
up.
it. We got it.
Just
We
read
got it.
it. Just read it.
All right. In mixed dentition, if I have a 16/46 in a crossbite, should I refer for early ortho?
Not early. It's too late if it's in crossbite. So that's not early ortho. But absolutely, you're already too late. Sorry, they were asking you, Simon. But
Yeah, for sure. Our profession is quite attuned to crossbites because crossbites don't self-correct, and they can drive all sorts of issues such as asymmetric growth. So one thing that we will be certain every orthodontist will be doing in early intervention is correction of crossbite. So absolutely, if you see a crossbite, see the thing is, if you have to consider if you see anything that isn't correct, at least take records and sit down with your providers of orthodontic care and ask, hey, is this something that you'll look after for me? We have to start taking records. We have to take photographs. We have to take measurements, just like our normal dental charts. If there is malocclusion, we should note it. Malocclusion is a problem. Just like periodontal disease is a problem, just like cavities is a problem, just like halitosis is a problem, we should note it in our charts. And then if it's outside of our capacity to manage or understand, we should be seeking consults from, from those who know more.
Okay, very good. So another question. Since nasal breathing is primary and normal, which medical organization declared that dentists should now be responsible for protracting both dentitions in an attempt to overcome a narrow posterior nasal airway anatomy?
go ahead, Simon. Yeah, I
Yeah,
argue
I
with
don't
the
think
premise.
there's, the thing is, although we're very much flag wavers for evidence-based practice, evidence-based practice is literally 30 years old. Right? Prior to the 2000s, everyone just did what they thought was best. We would put some research up to verify, but it's literally plaster on the table comparing what looks best. So a lot of the things that we used to do that appear to give us the outcomes that we wanted were not necessarily good for the big picture. We're dentists, we're obsessed by teeth. We want them to interdigitate nicely, and we want to have a good alignment. We were told that what we did in the mouth had no impact or bearing on the general health and well-being of the child. So we just did what we thought was best to get the teeth to mesh. We didn't do it specifically to harm. We didn't do it specifically to ignore potential harms. We just did the best that we could. So I think the point isn't to point fingers at, this orthodontist damaged this child. The point is to understand that we have new understandings today. And we also know that not everyone is open to these new awarenesses. And it's not for us to convince people who are not open to these concepts. Our point is just to gather the literature to show what is the new paradigm, and then just let those who are interested come and seek more knowledge.
I would say, in terms of those that are interested, really, when people get to me with their kid, and it's usually the female adult caregiver. In pediatrics, it's a mom. Okay. I'm getting more dads as we speak, but for the most part. And the mom, I got a 3, 4 year old with big dark circles under the eyes, can't sleep, breathe. And I just say, look, I hope dad's on board. If he isn't, let me have some time with him. Because if you aren't both on board, we're not ready to treat. I won't say I won't treat, but if you have buy-in from both parents that this is in the best short and long-term health interests of my baby, then you're home free. That kid will be putty in your hands. That's the best kept secret in orthodontics. If you have both parents on board, not for straight teeth, they'll get that, but this is in the best short and long-term health interests of my child, you're fine. You're going to be able to elicit cooperation. I just wish more people understood that. And it took me a while to learn it. They didn't teach me that in my pediatric behavior guidance training. They really didn't. I learned it mainly from the anthropologists. That's how hunter-gatherers raise their kids. They don't punish bad behavior, they ignore it, and they reward good behavior. It's so simple. You can treat 2, 3, 4 year olds with expanders every day of the week. We're doing it every day. So hope that makes sense.
Absolutely. And then one of the things that we forget is that as dentists, we're obsessed by gadgets. We're obsessed by appliances. We're obsessed by stuff that we can make. What we've got to do is understand that a child's posture, how they fight gravity in this existence, is something that the parents can help with when they raise their children. And it's up to us to teach parents how to improve the general oral posture and the nasal posture of a child. When we understand the interconnection between posture, function, and growth and development and health, and that's only possible when we explore the literature, because we're not making any of this up. This is all verified historically through research and development. This is all basic sciences. We have to move away from gadgets and go back to first principles of how do we as human beings thrive on this planet called the Earth. We need to know what environmental factors are throwing off the genetic potential. We need to be able to help parents understand how children breathe, how they sleep, how they eat. Like, we come back to the basics: air, water, food, and shelter, right? They're the 4 things that we have to tick off. But the quality of that air, the quality of that water, the quality of that food, the quality of that shelter has an impact on the lifespan and the health span of that child, right? Do we make that air polluted? Do we contaminate that water? Do we factory process that food? Do we use plastics in the fibers for that shelter? I don't know. This is what we are dealing with today. We have to understand how each of those things impacts us on a cellular level, on a macro level, on a growth and development level. When we understand it well enough, then we have a sound argument to present. And will parents be able to change everything in their life? No, absolutely not. But if they can change the big things enough, then we might get better life, better health in our children.
One of the things, Simon, that I've noticed with air pollution in, mainly large urban areas is that I will often pose the question to these people that I understand the particulate matter that's in the air. They can measure, pollution index and things like that. And I will often, 2 or 3 times, I pose the question on forums. Well, let's just say while we're trying to get this air pollution under control, maybe something that could immediately make a difference, especially with children. Does that polluted air cause more damage if it's breathed primarily through the mouth or the nose? Maybe we can get more people to become nose breathers. And while we're trying to solve the particulate matter in ambient air, maybe we can lessen the severity of the damage that it's causing. Not one time have I gotten a response. Nobody wants to talk to me about that. Well, maybe I'm posing the question differently, but air pollution in urban settings is a problem. But until we get it fixed, maybe by helping them become predominantly nose breathers, it'll do less damage. Does that make sense? It's a hypothetical
Absolutely.
question,
It's
but
understanding that we can't necessarily change. We don't necessarily want to become cave people living away from technology. What we have to understand is we can have the best of everything. We can live in the modern world with all the fantastic qualities of the technology to support us. But if we utilize our knowledge of what is good for us, we can avoid things that are bad for us. But this is where maybe to some degree you and I have to step in to help open the eyes of these healthcare providers that don't have that knowledge base, don't have the screening techniques to be able to understand. So our teaching of this information, I think, needs to be a big part of the lives that we take into the future.
All right, Simon, are you going to be in Argentina to Dr. Santos's?
Yes. In 2000.
Me too. I just got invited, so I'll see you there. We should start working on it.
I've got to step away to see a patient, but if you guys are still here, I'll be back in about 10 minutes.
Okay.
So
maybe
do you have more questions?
I
got 10 more minutes. Yeah.
Great. So we'll just quickly share a bit about the June event. It'll take 5 minutes, and then come back to questions for Kevin. And Simon will be back in about 5 or 10 minutes. So there's still about 250 of you guys, so we're here. Stay a little bit longer. So let me just see if I can share my screen. Where's my Zoom? So yes, our 6th annual 2-day introduction to early interceptive postural orthodontics will be June 6th and 7th, Friday and a Saturday, starting at 5 p.m. Eastern, New York time to midnight. It's a little bit late, but you don't have to take your day off work perhaps, and can sleep in the next day. But it's actually very early start for Simon in Melbourne, Australia, but it will be 5 p.m. start both days, Friday, Saturday, New York time. There's 14 hours of CE through TMJ Research Group, Complete Health Group, the PACE program for the CE verification. Very excited to have Kevin join us for 2 hours, actually, on Saturday, on day 2. He'll be going into more depth about his latest research that he touched upon tonight. Dr. Amanda Wilson, Professor Narinder Singh joined us last year in New Jersey, and we include the recordings from the entire 2-day program last year as a free bonus. So as soon as you register, you don't have to wait till June. You can get started for the entire 14 hours of recordings from last year's event, which was held at the Hilton. But so this year, once again, Dr. Boyd will be joining us on day 2. You can see the agenda, the full agenda, full details. You can go to our website, straightteethnaturally.com. There's no need to opt in or anything. You can see the full details of our 2-day event, /program. Regular price in May will be $1,500, but currently it's about $1,200. So that now also, as I said, includes as a bonus the 2-day intro recordings from last year's event. You get free lifetime membership to our private Facebook group with about 450 odd dentists. There's been about 500 people join over the last 5 years. And it's not just an introduction where, you need to necessarily do advanced training. We have 5 to 10% of attendees who are, orthodontists, and they run with it because we include practice templates, over 500 pages of very detailed protocols on how to use the appliances, the upper removable expansion appliances, the lower removable expansion appliances, all the video exercises for GoPEX, how to teach, how to get compliance diagnosis, the case presentation, clinical photography, everything is covered in the 2-day program. Of course, we do have advanced training for those who need and want it if you're relatively new to early interceptive protocols. Here's actually a 2-minute video of last year's event that would show. I don't think I've shown Kevin this, but you'll see excerpts of Kevin speaking last year, and Dr. Amanda Wilson was one of the other guest speakers, and some of the sharings from attendees. This is a short 2.5-minute video.
What's happening now is that our kids are they're just eating, in front of the TV, and they're not being supervised while they eat and talk, and they're not being corrected. And that's probably why a lot of the malocclusion is happening, and I never connected the dots on this.
Everything's about airway today, but not many people are doing anything about the posture and the breathing and getting people to change their behavior. As GoPEX teaches, they just say, I'm doing airway stuff.
It's the best thing out there for my child, for the patients in my practice. Life-changing. They can sleep better, breathe better. They could have proper posture. And in this day and age, every 2-3-year-old I see has an iPad with your mouth wide open.
It was excellent. I wasn't sure what to expect, but it was surpassed way more than I ever thought. It wasn't just a simple orthodontic type of thing. It really gave you a lot more than what you hear out there.
If we wait too long till the child is done growing, that we're not going to get as good of an outcome. And then we often have to extract teeth or do jaw surgeries or make a compromised outcome in order to give them a result that's straight teeth.
I've taken multiple courses throughout the years. I'm mainly for my own kids, trying to, get them better in many ways. And I found that Simon provided me with all the information that I needed and the treatment that my kids needed. I think not only did the course provide nuggets that I can implement right away on Monday when I go back, in terms of, intake surveys, questions, just questions to ask that I had not asked before. But then it also gives a roadmap of actual treatment, that I can do and that I can implement as well. So I thought that was really great about it.
He's passionate about what he's teaching.
It's life-changing and, and career-changing. I mean, I think that most pediatrics dentists go into pediatrics to make a positive effect on children's lives. And this just allows you to do it in a way that, you maybe only hoped would be something that you could do. So, and yes, please continue this. Please spread the word. It's really great. Yeah.
All right, some excerpts from last year's event, which was a fun event. About 100 people. We had about 60, 70 people and about 100 people online. This year is just going to be a virtual event. And we have this very special offer. It's kind of the, it's about 6 weeks away. So we thought, well, a lot of you guys have been thinking about it. And so for those of you who are joining tonight, we have a very special offer. So instead of the 1,200 pricing on our website, if you go to, straightteethnaturally.com/program, the main website, that's the pricing you'll see. But we have a special web link where it's straightteethnaturally.com/297. Now, it's not just $297. There is a second payment, but you can actually just join for the $297 initially, and you got a full 30 days to review everything, right? And if it's not for you, because you've got the last year's recordings and all the downloadable extra notes, hundreds of pages. And if you don't think it's applicable, then it's a full refund. But otherwise, if you feel it is what you're looking to do and implement, then there'll be just one other $700 charge on Friday, May 30th. So just about a week before the event. So in total, it'll be $997. So it's just an extra couple $100 off the current price. So this special, it's just for tonight and tomorrow, because I know a lot of people will be watching the recordings. So we'll send the recordings as soon as, Zoom lets us, download and then send it to you guys who are watching the recording. So, we'll email the recordings to everyone. So you still have all day tomorrow to think about it, until midnight, New York time tomorrow. We'll, take a couple of $100 off. There may be some of you who actually paid more than the $997. Just send us an email and we'll refund you the difference. So thanks for joining tonight. You guys get a little bit of a refund if you paid previous prices that were more than $997. Anyway, so that is the special $297. If you go to the website straightteethnaturally.com, I'll put the link shortly in the whatchamacallit in the Zoom chat. But this is what you'll see. There's about a day's left. $297 up front and $700 at the end of May, essentially. And you can see the full agenda and the full details by clicking on this link, and make sure you just go back to /297 to get the special. Now there's a lot of you guys who are allied health professionals, myofunctional therapists, speech language pathologists, dental hygienists, etc. The special we have tonight is just $275. We regularly sell it for $497, and normally it's roughly half the price. But we've got this really good special for those of you, because we know that you're out there and working so closely with dentists and the general public. The GoPex exercises in particular is something that is just an amazing protocol for young kids. So just $275 one-time payment. You just go to straightteethnaturally.com/275. Once again, that ends tomorrow. All right, so just go to the website and you'll see the big discount. It's just $275. All right. Now, there's some of you who are past students. A lot of you guys have joined us perhaps in previous years. If you'd like to sign up for a refresher and join us in June, just send us an email, info@straightteethnaturally, and it's just $297. A one-time payment. And if you're from other countries and would like to inquire about our country specials, because we do have specials depending on which country you're based in, send us an email before tomorrow, and we'll let us know which country you're based in, and we'll send you the details of those specials. Alrighty-o. So on that note, I believe that's our actually, speaking of different countries, Kevin, do you want to quickly mention your upcoming events? If you can't join us in June, you can certainly join Kevin. Kevin, you're in Malaysia. This is where Simon and I were originally from before we migrated to Australia in the early 70s as little toddlers. So Kevin, you're still there?
Yeah, I'm leaving, departing
In 2
Chicago Wednesday.
Yes.
And get there 3 days later because I crossed the international date line. So
Yeah.
go figure. It's going to be marvelous. We were in Melbourne last year, and we're doing it again this year. I'm speaking with Sharon Moore,
Fantastic.
JJ, and Donnie and Daniel. Yeah, it's a great group. And then the
Fantastic.
Academy of Pediatric
Oh,
Dentistry has
yes.
their annual meeting in Denver.
Denver, May
And I'm
24th.
speaking of, yep, Loria Najadas is an amazing pediatric dentist in Dallas. She's part of the Endeavor group. Some of you know about Endeavor, which has now become part of the AAPMD, uh, American Academy of Physiologic and Medical Dentistry. And there's a couple other big events coming up. You might have heard me talk about Argentina. Simon and I will both be with Maria
That's next year, right? That'll be
in
next year.
Santo. Yeah, in
2026.
October of 2026. That's going to be a big one.
What month is that, Simon? Kevin?
I
October?
think it's in August. I think or October. I think it's October
Oh,
of
okay.
26.
Good.
Yeah.
And we're going to email everyone who's registered, whether you're on the getting the recordings, this folder of articles that Kevin kindly shared with us. So I'm excited to share a lot of these different articles for those who want to get into a lot more aspects of overall health. And so thank you for sharing that. So let's
Oh
open.
yeah, and
Oh,
could
go
you
ahead.
show like the first 4 or 5 slides of that slide set I sent you?
Oh, okay.
Just to
All
go
right.
through them.
Yeah, I'll do that
You know,
quickly, and then we'll open up to questions again. Simon's back. So
and then
there's this.
you could send those slides if people want. It's 20 slides, and it's sort of a compendium of what I'm going to be talking about in Kuala Lumpur and in Denver. But I would love to share these. The big deal is oxidative stress, and
Well, we'll
what
convert it. We'll
happened.
convert it to a PDF and share the PDF.
Yeah, do that. Okay, well that's it. I didn't want to turn it into a slideshow. I just there's some these are things I'll show in June.
Fantastic. Now we still got 200 people on, which is fantastic. So we'll Simon's back. It's his lunch break in Australia, and Kevin's still nibbling on his dinner,
Oh yeah.
probably.
I was just quickly skimming through some of the questions, and a lot of the questions that I raised is indicative of the problem that we've had with kind of uncontrolled early interception, right? Because our profession isn't formally training dentists, pediatric dentists, or even orthodontists to work with early intervention, early interception. A lot of us are just kind of making things up as we go along. And the problem when you are dealing with the concept of expansion, a little expansion is good, so a lot of expansion must be better, is that I spend a lot of time referencing literature in what the norms are, what is expected minimum and maximums for dimensions in order for things to fit properly. Right? Everything in its own place with its own space. And I've been fortunate enough to be able to reference that literature and set very tight parameters, very tight protocols on how much to expand, how to gauge the level that's appropriate for the age, how to gauge the level that is appropriate for the size of the teeth, the size of the tongue. We have minimums and maximums, and we have to make sure that we're treating the child as a whole and not just a maxilla. All right, the biggest problem is there's no one on earth who can't expand a maxilla. But if we don't marry up the mandibular arch to retain a functional occlusion, then it's just literally a waste of time. It's literally patting yourself on the back for doing one of many things well, and then ignoring everything else. So we spend a lot of time in our program training you to the literature behind what are the correct parameters, how much to expand, when to expand. I mean, there was a question about, do we just keep expanding until someone taps us on the shoulder and says that's enough? Or do we have a set parameter? And the answer is yes, we have set parameters. Do we just do the maxilla until we've got a Brody bite and the bite no longer fits? And the answer is no. We have the capacity to develop the lower arch as well, right? That's one of the unique things that I've been able to add into the equation is modifying the Schwartz appliances that were pioneered in the last century and perfected at the Michigan University protocols. And I've been able to create balance where balance is missing. See, this is the key, right? We can't fix everything. We can't cure anything, right? But we're here to improve the overall balance. We're here to make sure that we're not obsessing about one corner when there is a whole that we have to look after.
So Simon, I would add to what you said, because those maxims are all right. Just don't keep going until somebody taps you on the shoulder, but the Brody bite, and most people here know what a Brody bite is, and that is when, you get posterior buccal overjet that exceeds, the lower posterior segment, buccal, that you're in a reverse crossbite, they call it.
Yeah, scissors bite.
But scissors bite. But Dr. McNamara even has it in his textbook, and he calls it spontaneous class 2 correction. But what he found, and he was very brave, and he knew these kids needed more expansion, maybe that would even send them into a borderline Brody bite. And then he started doing it deliberately, especially when they were class 2 mandibular retrognathic. And what would that kid do to try to make it right? He would shift his jaw forward so that he was no longer in Brody bite, but it felt better so it was a functional appliance. And McNamara called it a spontaneous class 2 correction.
Yeah,
but
he
no,
also
it was a
added
deliberate.
in a lower Schwartz appliance so that he could get more out of the whole equation.
But not every time. I mean, he's the one who introduced me to the Schwartz. Everyone told him you can't expand the mandible. And what he would say is, you're right, you can't suturally expand the mandible because there's no suture there. You can upright posterior warped segments. You can upright the linguoverted, molars,
Absolutely.
so that they have better axial
Yeah,
inclination.
absolutely. All we're doing is level and aligning, right? What's the first step in orthodontics? Level and align, right? That's all we're doing. And we're just doing it in a primary and a mixed dentition process. We aren't doing anything that is illegal. We're not doing anything that is non-evidence based. There are clinicians who practice dentistry that has no scientific evidence basis to it, right? I've done dentistry that has no literature support, but I don't teach that dentistry. Right? The dentistry I teach is all evidence-based. I'm researching myself in my own practice, some of the techniques that I've used that don't have evidence bases, but I'm trying to create evidence bases for it. When I get published, then I'll teach it. But it's very important for the uninitiated to be able to discern that your teachers don't always look after you as a clinician, right? They've just got a product to sell. They've just got a technique that they like. Right? We have to make sure that you learn the fundamentals, that you learn the first principles, so that you can criticize what I teach, so that you can criticize what Kevin teaches, and make of it what you need to improve your practice while making your practice defensible, right? What we have to do must be defensible. So it has to have a logic behind it. It has to have set parameters. Right? So that's what we are teaching. We're teaching you how to create a defensible practice that will be predictable, that will be favorable and consistent. That's the goal. And sometimes it means there are things that you can't treat. Sometimes there are children that you can't treat. And that's life, right? You can't fix everything. There's no primary care physician who's consistently root filling third molars. Why? Because sometimes there are things that are really hard to do that we just can't do.
Right.
So I think that the success criteria, I mean, Simon, Simon and I were trained according to conventional orthodontic standards. I mean, in my program in Iowa, you better be able to stand up to the American Board of Orthodontics. That's how they trained us. Well, right now, success criteria in my practice is everything that Simon said. I mean, we want a wide, forward, non-vertical growing patient as early in life as possible that has structure that's conducive to habitual nose breathing while they're awake and asleep. However, when we first meet a child, we do an intake that assesses risk for sleep apnea. We do, the Shervin 23 questionnaire. We got it, shortened, but we want to know how that kid is sleeping and breathing. And at every single visit, we're okay, what's the molar classification, overbite, overjet? How is the kid sleeping and breathing relative to when they started? And sometimes they get worse before they get better. And you tell the parents, oh, everything, they don't snore, they don't wet the bed, but they're still grinding. Well, guess what? Bruxism is the last thing to go. I always tell everybody that. But, so what is your success criteria? Well, it's based upon what your intake is. You're doing supplemetrics and you're analyzing the panoramics and the photos, but you must take a pre-treatment sleep assessment of this child's ability to sleep and breathe through the nose. That's how you know you're
Absolutely.
and as your practice grows, everybody on your team, the parents are coming in, and almost always things stop getting worse and then they start to get better. I never promise it. I'm a dentist. I do dentistry. I can't promise it, but I can create structure in your child that will be conducive to habitual nose breathing. But we need myofunctional therapy. They got to quit sucking their vegetables through a pouch. They got to start chewing. These are things you must start, to talk to people about at the very beginning. And then success criteria becomes something totally different than what it used to be in orthodontics.
Okay, so there's some questions about purchasing the GoPex book. We are not the publishers. We're just Simon is just the co-author. But you can go to forwardontics.com and purchase it through Dr. Sandra Khan's website. But we don't have any control over that. But we give away the ebook version for free, which we're just sending on the chat. And there's no licensing in terms of the ebook. You can share it with families and anyone. We want to, give it away for free, essentially. But if you really do want a physical copy, we don't get royalties. You can purchase it Dr. Sandra Khan's website, forwardontics.com. I sent the link in the general chat. Simon, there's a few other questions. Do you want to answer them, or if you want to stay for 5 more minutes? It's getting a little late.
Well, we've all got lives to live.
Okay, well,
So,
I think
I think we can
we've covered.
answer a lot of these questions in June.
Yeah, in June. So I'm going to wrap up. Thank you, Kevin, so much for joining us, Dr. Boyd, and we're looking so forward to having you join us for a 2-hour keynote presentation on June 7th in particular, via live stream. So we do hope there's already a few people who've joined. Welcome, Dr. Tolley and Jeremiah and Dr. Kopak for joining, and others. The special that we have, I'll mention again in a minute, but thank you, Kevin, for joining us. We'll see you in June, but have a safe trip to Malaysia. Send our regards to the beautiful country where we were born, and enjoy your travels, and we'll see you in June.
Great. Thanks for having me. I got to sign off. Simon,
Thank you so much, Kevin.
And if anybody has questions of what my 2 hours in June, Kevin, please cover this. If you get any of that, I will, do some extra research and try to answer specific questions.
Okay. So do send us email when I email you guys all the resources that Dr. Boyd I'll upload this to Google Drive, and we'll email the recordings as well of tonight's event. Send us a reply email if you would like us to forward the questions. We'll compile them and send them over to Kevin, especially if you're attending in June, and then that way he can, help customize the experience a little bit. So once again, for dentists, got a 24-hour special. Join us either tonight or tomorrow. StraightTeethNaturally.com. We're going to give you $200 off the current price, and in May it's going to jump to $1,500. So StraightTeethNaturally.com/297. Pay $297 initially. 30 days later, end of May, roughly Friday, May 30th, we'll charge the $700 additional, so $997 total. 30-day money-back guarantee. So you just join for that initial payment. Check out the program. The website will look like this when you go to StraightTeethNaturally.com/297. And for allied health professionals, it's just $275. We welcome, everyone who is in this field to make a difference and who work with all the other dentists in this field as well. So it's just $275. Just go to StraightTeethNaturally.com/275. Normally it'll be $497 in May, but join at this extra discount for making the effort of joining us tonight. And once again, if you're a past student, it's just $297 for a refresher. Email us. We don't have a checkout page set up for that, but just send us an email and we'll sort that out. But if you're from other countries besides the US, we do have country specials where obviously you can price it obviously in your local currency and make it a lot more affordable depending on where you're based. So just let us know. Email us which country you're from. Just so long as you email us by tomorrow, we'll extend our country special. Alrighty-o. Thank you for joining us. And, it's been great hosting tonight. It's over 100 of you guys still on. Get some rest. And hopefully you've had some inspiration from Dr. Kevin and my brother. Good evening, good night, good morning, wherever you are. Take care. We'll see you soon.